Yes, no?
We can hear you. You always talk very.
You know, usually I bring down the house. Anyway, once again, welcome to each of you to this meeting. There it is. I want to welcome you on behalf of the Mississippi State Medical Association. For those of you that don't know me, that maybe one or two, I'm Dr. Alfio Rausa. I came to Mississippi just for 1 year in 1966, and 47 years later, I'm still here.
And now going home.
I have a home. It's in Greenwood. And the reason I got to stay, supposedly, is because my wife and I planted tomatoes that first year we were here, and we got Mississippi gumbo between our toes. And once you get Mississippi gumbo between your toes, you can't leave. Amen. That's it. Anyway, I started out with one county, LaFleur County, and over the last 47 years, my territory has expanded. I now have a jurisdiction that runs 18 counties, what I call the Northwest Territory, bounded by the Mississippi River, the Tennessee line, I-55, Highway 12, and there's an appendage that's outside the box called Talcott County. And that makes 18 counties that I have jurisdiction over. And I have enjoyed what I do. And most of what I do is outside the walls of the health department. I'm more oriented to community, and not that I'm opposed to public health. And so you have to have somebody that pays your bills, and the Board of Health has been real nice for the last 47 years to pay them. Anyway, we've entitled the meeting today, Solutions for Covering the Uninsured. This has come about as a result of a resolution that was passed by the Mississippi House, Mississippi Physician Association House of Delegates, and to try to reevaluate Mississippi State Medical Association's position on Medicaid expansion. So the Board of Trustees and the Council on Medical Service, and I'm chairman of that council, were directed to bring together a public health community, Mississippi Health Policy Institute, the governor's office, interested parties, before the end of the year, in the hope that our members might reach a consensus on the issue of Medicaid expansion. After reviewing the resolution, the Board of Trustees expanded the goal of its intent to look at a greater issue of any and all possible solutions in providing health care coverage for the uninsured, regardless of the Medicaid enrollment qualifications as they exist now, or if expanded. This allows us to look at the issue from a broader perspective and have a full and robust discussion, which we'll do at the end of the presentation. Today we have in the audience members of the Board of Trustees of State Medical, some people that serve as advisors to the board, members of the Council on Medical Service, leaders from a variety of specialty medical societies for state medical, past presidents of State Medical Association, representatives from the State Health Department, legislative leaders, and finally we round out the group with many other members of the State Medical Association and some of their invited guests. Hopefully when you came in, well, in advance, those that had pre-registered should have gotten a nice big packet of reference material. And today, as you came in and registered, you should have gotten a packet kind of late to read it. And you know, there's much material out there, blogs, reports, and this is a topic that has been written and spoken of in many ways. And so what you have in your hand is just a small sampling of the most current information available. Our focus today is to look at options for covering the uninsured in the state. This is not a discussion about how the Medicaid program functions today, or any problems with Mississippi CAN, or any other alternative program. To cover the topic at hand fully, we will hear from three speakers. One, to give us a few updated facts about the uninsured population in Mississippi. One, to review how Medicaid expansion would benefit the state. And one, to discuss other ways to cover the uninsured. After each speaker, we'll allow a couple of questions. And once all the presentations are made, hopefully none of the speakers are going to run away, we'll have a Q&A session and a closing discussion. Our first speaker is Ms. Theresa Hanna. She is currently the Executive Director at the Center for Mississippi Health Policy. Prior to her role at the Center for Mississippi Health Policy, she was State Insurance Administrator and at the State Department of Finance Administration. And prior to that, she was Director of Policy and Planning at the State Health Department. The Center for Mississippi Health Policy is an independent, nonpartisan, non-profit organization that provides objective information to inform us about health policy decisions. They serve as a catalyst for public health policy debate, providing information to policymakers, the general public, and communicating research findings that will stimulate dialogue and inform decision makers. The focus of the center is on the application of research to relevant health policy issues rather than developing original research. They recently completed a study, after a 5-year study, of the impact of the school health legislation that was passed several years ago, and things are getting better. And hopefully today, as a result of our speak, we'll get our health policies fixed. Please welcome to Ms. Theresa Hanna.
Good afternoon. Thank you, Dr. Rausa, for the introduction to the Center for Mississippi Health Policy. I did want to start off by saying that we're an independent nonprofit organization and we do research and analysis. Yes. We're not an advocacy organization. We don't advocate or lobby for any particular solution. We try to present objective information, and specifically for today, we do not have a position in support of or in opposition to healthcare exchange, the Medicaid expansion, or the Affordable Care Act. I'm going to talk to you about some of the research we've done on the uninsured in Mississippi to hopefully set the stage for the rest of your discussion. And let's start off with looking at, in general, the entire population of the state. And we have about an 18% uninsurance rate. It's higher than the national average, but we want to look more closely at who those uninsured are. We know that children are eligible for Medicaid or CHIP up to 200% of poverty, and the elderly, for the most part, are going to be eligible for Medicare. So who we really want to look at are adults, 19 to 64 years of age. And if you look at adults, you'll see the uninsurance rate for that group is about 26%. About half have private employment-based insurance. Another 5% have private insurance that they purchase. 13% with public coverage, and like I said, about a 26% uninsurance rate. Now, uninsurance is very closely associated with poverty, and there's a very close association between income and insurance coverage. So if you look at adults, 19 to 64, by their poverty level, you'll see those below 100% of federal poverty level, that almost close to half are uninsured. And then as income goes up, by the time you get above 400% of poverty, there's only an 8% uninsurance rate. There's a statistically significant relationship there between uninsurance and poverty level. So the population related to the target population for Medicaid expansion are people, adults 19 to 64, who are at or below 138% of the federal poverty level. So we looked at census data and looked specifically at that group, those that have incomes at or below 138% of the federal poverty level, to look at their characteristics. And what you see there is about 40% of that group is currently uninsured, and only 18% have private employment-based coverage. When you came in, you could have picked up one of these. It's a fact sheet that we've done looking at those adults below 138% of poverty and also below 400% of poverty. by county, because there's just a lot of interest in breaking this kind of information out by geographic area of the state. So we have these available for you if you're interested in looking at some of those uninsured rates by county. As I mentioned earlier, children up to 200% of poverty are covered by Medicaid or CHIP, and the elderly are covered by Medicare, plus you have Medicaid covering some of the elderly and the disabled. And then in Mississippi, we have pregnant women are covered up to 185% of poverty by Medicaid. And then we have, for some parents, those with the Temporary Assistance for Needy Families program, they can be eligible for Medicaid if they're parents. Those income levels are anywhere around 24% of the federal poverty level or 44% if they're working. Who's not really covered by Medicaid are childless adults. Childless adults are not going to be covered unless they fall into one of the categorical areas, such as being disabled. So when we look at who is going to be eligible for the Medicaid expansion, it's primarily then going to be those childless adults and some of the parents. So the new group, the target population, is primarily younger than those that are currently on Medicaid, and they're not disabled. And because it's a very different kind of group than who's currently on Medicaid, the law allows for the state, if the state chooses to expand Medicaid, to have a different set of benefits. The state does not have to just expand traditional Medicaid to this new group. They can set up what's called like a benchmark of a plan that they want it to look like. For instance, when the state set up the Children's Health Insurance Program, the state wanted it to be a privately insured program and set it to match as a benchmark the state employee plan coverage for children. And so that was set up totally different outside of Medicaid. That was one of the options the state had. Well, states have that same kind of option with this new target population. The state also can have a different delivery model. If you have fee-for-service Medicaid, you can have managed care in the target population group or vice versa. You don't necessarily have to have the same delivery model that you have with traditional Medicaid. So when we look at this group of the 19 to 64-year-olds who are might be eligible under the target group, under 138% of poverty, what we find are most of them are low-wage workers. So we looked at the census data where you can look at the occupations of uninsured adults below 138% of poverty. These are the primary occupations for that group. And what you see are these are cashiers and cooks and carpenters and childcare workers and cleaners, laborers. As I mentioned, they're mainly low-wage workers who do not have access to insurance through their employer, or they're not eligible, or they can't afford it. And if you look at accessibility employer coverage, what you find is it's very often not available to low-wage workers. Nationally, only a third of low-wage workers are eligible for coverage through an employer. And small employers also are more likely not to offer insurance. And in Mississippi, most employers are small, and by small I mean less than 50 employees. Also, a lot of them are part-time workers, and part-time workers are rarely eligible for employer coverage. And if you look at private business establishments in Mississippi, you'll find that most of them are small, most of them are fewer than 50 employees. Most of those do not offer health insurance. So of all employers in the state, you've got 50% who are small employers who do not offer insurance. You have another 20% who are small employers who do offer insurance. You've got 28% who are large employers, that means 50 or more employees, and they generally offer insurance, and only 2% are large employers that do not offer insurance. And looking at private sector workers in Mississippi, in general, both large and small employers, we see that about 80% of them have insurance offered, and that's because most employees do work for large employers by size. 62% are eligible for coverage, and 47% are enrolled. But if you look at low-wage workers in Mississippi, you'll find that only 68% of those are offered insurance, and only 44% are eligible for coverage, and 25% are actually enrolled in private employment-based coverage. So in terms of coverage implications related to Medicaid expansion, most of the estimates of how many people might enroll under the Medicaid expansion center around 300,000. Now that is assuming 100% take up and also assuming that even those that now have insurance would move into Medicaid. That, even assuming that happens, you're looking at a major change in terms of coverage. A large number of people would move from being uninsured to getting coverage. And most of those are these low-wage workers who don't have access to employment-based coverage. Those below 100% of poverty will not have access to subsidies under the exchange. Or what they now call the marketplace, the healthcare marketplace, is going to offer subsidized premiums for people between 100 and 400% of poverty. So in this group, those between 100 and 138% of poverty may be able to access subsidized coverage through the exchange. Those below 100% will not have access to the subsidies, so they're left without a lot of other options. Those between 100 and 138% of poverty, if they access coverage through the exchange and they work for a large employer who doesn't offer affordable minimum value insurance, that may trigger a penalty for that employer, whereas it might not if they were on Medicaid, and it might. And if you may read a little bit about employers who are concerned about that, and that's the whole point, is if they get a subsidy and it's a large employer, it may trigger a penalty for them. Now, what do we know about the health of the expansion population? Well, there was an article in the June issue of JAMA just recently that they had studied the population below 138% of poverty using NHANES data, the National Health Assessment Nutrition Examination Survey. They looked at people who had Medicaid and other low-income populations that did not and compared the two. Their key findings were that the group that did not have Medicaid was less likely to have high blood pressure, high cholesterol, or diabetes. If they did, it tended to be undiagnosed or uncontrolled, and they were less likely to have seen a physician in the previous year and more likely to use the emergency department for medical care. There are a few other studies that we've looked at to try to look at what health differences we see with this expansion population. One of the studies you'll see quoted a lot is the Oregon study. A few years ago, Oregon was going to have a Medicaid expansion. They couldn't afford for everybody who might be eligible to enroll, so they held a lottery. And people who won the lottery got Medicaid, and those that did not. It sort of set up this very natural experimental design. So researchers have been very anxious to study what happened to those who enrolled in Medicaid and those who did not. And there have been several articles published, primarily 1 year after the expansion and then 2 years after the expansion. So what they found in general is that overall utilization of services did increase for those who enrolled in Medicaid, but they did not think it was related to pent-up demand because it didn't happen in that first 6 months. So it wasn't the kind of, I'm sick, I'm waiting for coverage, and as soon as I get coverage, I'm going to go get health care. It was more over that first year period of time, and it tended to be preventive and primary care related. They saw a significant increase in compliance with recommended preventive care. They saw a significant increase in access to primary care services in general. The other study that has been around for a very long time is the RAND insurance experiment. And it in general says that when people have to pay more, they use fewer services. And that applies to care across the board, whether it's considered medically necessary or not. Just in general, when people have to pay more out of pocket, they use less, and utilization is down. And in general, when you look at the majority of studies around the uninsured, what you'll see is that the uninsured generally are just less likely to seek care. So in Mississippi, if you look at the behavioral risk factor survey that's done by CDC every year, Mississippi stands out, and that one is that we're more likely to report not being able to see a doctor because of cost than people in any of the other states. And if you look at the health indicators in Mississippi, you see a sort of a trend of low access to preventive and primary care and then high rates of disability and premature death. And I use a couple of examples. These data are from the Dartmouth Atlas of Healthcare, and they look at hospital areas across the nation using Medicare data. And this shows preventable hospitalizations by hospital area. The dark being higher rates of hospitalizations that they consider in their algorithm to be preventable for the most part. The lighter colors are lower rates. And what you see is Mississippi is almost entirely covered by the dark color. We have some of the highest rates of preventable hospitalizations nationwide. Another example is with diabetes. This is also from the Dartmouth Atlas of Healthcare. And you see the leg amputation rates on the left. Darker color are higher rates of leg amputations. The lighter color are lower rates. And once again, Mississippi has some of the highest rates of leg amputations related to diabetes. But on the other side, if you look, hemoglobin A1C testing rates, which is typically done in a primary care setting, we have just the opposite. We have very low rates, where you might think because we have such high rates of diabetes, we would also have high rates of hemoglobin A1C testing. We have very low rates of hemoglobin A1C testing. Other example relates to breast cancer. We really do not have a high rate relative to other states for female breast cancer. We rank 38th in the country in terms of incidence rates. But you may hear, well, we have such high rates of breast cancer because of death rates. We're 4th in the nation in terms of cancer deaths due to breast cancer. Large part because when we do find it, we find it later. Once again, an indicator of lack of early preventive and primary care. And related to perinatal issues, Medicaid covers pregnant women when they are pregnant and then up to 60 days postpartum. But in between time, they don't have the Medicaid coverage. So we looked at who had coverage when they were not pregnant. And if you look at generally women of childbearing age in the low income category in Mississippi, 45% of those are uninsured. And if you look at pregnant women who are surveyed by the health department annually, 36% of women in 2010 reported that they were uninsured prior to their pregnancy. So when we try to work on infant mortality issues in the state, one of the areas is trying to improve the health of women prior to pregnancy and in between pregnancies, and that gets impacted by the lack of insurance coverage. So we've got some of the barriers to care related to lack of access to preventive and primary care. It's not all related to having coverage, though. Just having a Medicaid card does not mean it improves your health, any more than having a Blue Cross card means that it's going to improve your health. There are a lot of delivery system issues that are associated as well, including the fact that we already have a shortage of primary care providers. And I know there's a lot of work going on in the state in terms of the physician workforce at UMC now. There are additional funds being given nationally to community health centers to try to beef up their capacity. There's a lot of work being done. We still, even if we were to improve coverage rates through the marketplace, Medicaid expansion, or whatever, we still have these delivery system issues that we need to work at. There's another handout that I had at the front desk on Medicaid expansion, which we'll be updating before this next session with updated information. We have several different issue briefs that we produce. If you're interested in keeping up with that, you can register on our website for our email list, and you'll be notified when we have new publications, and you can follow us on Twitter. And I'll be available for questions.
Wow.
Afterwards.
You made up for lost time. You finished right on time, even though we started just 10 minutes late. And you're not going to be long. Floor is now open for some questions for Ms. Hanna. Questions? We'll move on to the next speaker and we'll do the question and answer period. Next, we have a presentation on the benefits of Medicaid expansion. Access to health care makes a difference. And our next speaker is Ed Sivak. Ed is the director of the Mississippi Economic Policy Center, and during his tenure at the Policy Center of the microphone, he has supervised the research and writing of numerous publications on the state budget, issues affecting working poor families, and high-cost lending. This policy center does research and analysis on issues that matter to Mississippi. Please welcome Ed Sivak.
Well, good afternoon. Thank you for having me here today. I really appreciate the opportunity to be here and speak before this group. It's really a privilege, especially with the other individuals that you've invited to speak. I want to commend you all, too, on the charge that you put out there to expand the discussion to look for solutions. I really think that's the right charge. At the end of the day, we need to figure out how are we going to cover people so that people can be healthier, so that they can be more productive, so that we can have a system that builds the type of economy in Mississippi that moves forward and creates progress. And so with that, I'm going to start with an economic backdrop within the state. What you see here are what's happened with jobs since January of 1996. And you see the ebb and the flow, and there's some noticeable, memorable things that happen. So, for example, in the middle where you see that big drop, that was obviously Hurricane Katrina. The two peaks, right before the recession, we actually had the highest number of jobs that we'd ever had. And then we had the Great Recession, and we're climbing back out. The last time I spoke to this group, I mentioned that we had the same number of jobs that we had in 1996, and thankfully I can throw that talking point away. We're back to 08 levels. And so I think this is important because as we have recovered, there's been a number of things that have risen to the top when looking at the state's economy that I think are worth pointing out. So the first is that the state economist has pointed out that much of the growth has been part-time jobs, temporary jobs. They're not the best jobs, they're not the type of jobs we really want to be celebrating. Nonetheless, job growth is good, but we know those aren't the type of jobs that have health insurance associated with them. The second is when you start looking at projections, you all see some other disturbing trends. So this was a study that was published by Georgetown. They have a workforce education center. And if you look at the percentage of jobs in Mississippi in 2018 that are going to require post-secondary education, we're at the bottom there, 54%. No shock, we're used to occupying that space, but what it does for me is it lifts up the point that many of the jobs on the other side of that bar are the ones that have health insurance attached to them. And again, the point is how do we increase covered lives? You see we're much lower than the national average. The other disturbing statistic that came out of this study was kind of what the overall proportion of jobs will look like in 2018. So Mississippi will rank 4th in the proportion of jobs in its state's economy for high school dropouts. For the proportion of jobs for college graduates, we'll rank 50th. So again, it's something we all need to work on, but it also, I think, has implications for our employer-sponsored health insurance. And this is what it's looked like over the last little over a decade. These are census data. And this is happening all over the country. We've seen that it's fallen. Now, a lot of that, if you look at the Medicaid growth, a lot of it, on the flip side, we do see a significant increase in the Medicaid growth. But you don't see the growth in the Medicaid population eclipse the loss in employer-sponsored health insurance. So we have 210,000 fewer people with employer-sponsored insurance today as we did back in the first part of the decade. Some other snapshots about how expansion, in particular, if you are looking to expansion as a solution for increasing covered lives, is really what's going on across the country. And in some ways, this may reflect political considerations, and I want to try to stay out of the political discussion and just throw the numbers up there. But the South, by and large, has a large percentage of its population that's uninsured relative to the other states that are moving forward with expansion. There's some other characteristics associated with that. So if you look at where people live or look at people's race and who's uninsured, we see that a high percentage of blacks live in states that are not moving forward with expansion. So what does that mean for Mississippi? Well, for the first time since really the early part of the 20th century, Mississippi now has more children of color than it does white children. And you know, if you project out population trends, it will be quite a long time before Mississippi is a majority-minority state. However, if we don't figure out a way to reduce the disparities in health, in jobs, and education, the economic potential for the whole state is really capped. And as we discuss about how we increase covered lives, I really think that we should keep in mind how our economy is structured, how our demographics are changing, because they carry important considerations for how you all in particular run your businesses, run your practices, for hospitals, all of those things. Now a lot of the discussion or debate, or if you want to get into the fight, whatever you want to call it, around Medicaid expansion during the last session, one of the points that was lifted up was the notion that the Medicaid disproportionate share hospital payments will be cut, and that's one of the reasons that we need to expand to make up for that cut. Well, CMS released their guidance, and what we saw was that the cuts were really, in Mississippi, they were very small, and the reason for that was, the Supreme Court ruling was pretty clear, that you can't coerce a state to expand its Medicaid program, and were CMS to make that formula punitive, someone could have challenged it. That was at least one explanation that I had heard. But if you look at the larger healthcare finance network, I think it's important that we look at these other payment cuts that are, a factor or a function of the sequestration of the Budget Control Act, Taxpayer Relief Act, a number of different acts of Congress. And this is what the Mississippi Hospital Association projects out what the cuts will look like over the next, from 2014 to 2022. So you see, in 2014, it's $145 million. You get into the out years, you're up, high 300s, $400 million. And I mean, these are real dollars, right? And so some of you all know that there are many hospitals. If you're a critical access hospital, for example, in the state where margins are very thin, this could have a deleterious effect on keeping the hospital open, having to find someone to buy it. The other thing that this lifts up for me is when we talk about, well, if we do expand, how are we going to pay for it? Because there will be state costs. I mean, we need to just be honest with ourselves. There will be costs if we expand Medicaid. And so, one question that's raised is, are we going to have to raise taxes to pay for them? Maybe, we won't know until we get there. But I also think that if you have a critical access hospital, if you have a county hospital that is on the edge, they're going to have to turn to their board of supervisors to raise taxes to stay open too. So if there's not a way to increase revenue for some of these hospitals, I mean, there's going to be taxes one way or the other. And so whether they're property taxes or state taxes, or maybe we figure our jobs picture out, we can grow our way out of it. We'll see, but I'm not hopeful on that front. So this is the IHL projections for the cost of Medicaid expansion. Now, there are a number of different studies. Obviously, that have been done. The Division of Medicaid commissioned one as well. I picked the Mississippi Institute for Higher Learning because it's, I consider it to be their analysis is sound, and I consider it to be unbiased, And so what did they find? They, basically the bottom, and I should have had numbers on the bottom bars, and I actually wrote down, if you go to the out year, I'll tell you what those costs are for comparison purposes. It's 145 million, the blue bar, which is the state cost, and that would essentially be what the state was putting up, and 86 million, which is the red bar, that's the net cost. There would be, the green bars are the federal revenue, the federal costs too, you gotta pay for them somewhere. And so, but it's federal money that is coming into the state. And so, when you have that much money coming in, there's going to be demand that's created. There will be some additional income that's generated. So there will be some new taxes that are generated. So the net costs are the red bars. And the out years, again, that's $86 million. But I think, if you step back and look at this question of increasing covered lives, and you look at some of the numbers that Theresa put up there, is there a solution on the table that can bring in this much money into the state to begin addressing some of these challenges? I haven't seen it. I mean, that's one of the reasons why we've taken an active position, or we've supported Medicaid expansion. We've actively advocated for it because we think that there are definite positive benefits to bringing in this federal money to address some of the challenges. Again, acknowledging that there will be costs. I don't want to try to avoid that point. So, as we move forward, let me just say one more thing back on this. There's been a lot of different economic impact studies done around the nation, really. Some of the ones there's been a couple in Alabama, there's been one in Arkansas, Kentucky, North Carolina. All of them have jobs figures associated with it. I didn't really go into it here. I mean, I think there will be some jobs that are generated if you bring in this much federal money. There's going to be challenges in building up the physician workforce. It takes a long time, as you know, to train a physician and other healthcare providers. But also, the jobs that I think would be filled in more quickly are those other medical positions and coding positions, and the support structure that comes up around the delivery system. I also want to make a point that, so this study found that there would be 9,000 jobs that would be created. Those job numbers aren't that far off of what they found in other states. And to give you a sense of is that conservative, is that aggressive? I think it's conservative. Alabama, one study in Alabama said they had 30,000 jobs in Alabama. So I kind of think if they're going that far out, this is probably, fairly, conservative. So some things to consider as y'all debate this issue and have this conversation is, the changing economy suggests that there's going to be fewer people in Mississippi with employer-sponsored health insurance. So how do we increase the people who do have coverage? Medicaid expansion is one option to do that. Population growth is most likely to be among groups that are more likely to be uninsured. That's just a fact of our existence here in Mississippi. Hospitals are going to need to lay off staff and cut services to manage deficit reduction. So there has been stories, we've heard them in different parts of the state where there has been the need for reductions. And as you read the press statements of the administrators from these hospitals, they point to the fact that it's changing government reimbursements, it's just the way the whole financing structure is changing. And that, I think, as a discussion about whether or not to move forward with this or something else is entertained, that's obviously got to be a key part of the discussion. This last point also, in terms of just our uninsured population, I think if we can't figure out how to increase more people being covered, we're going to be at a competitive disadvantage. So we know Arkansas is moving forward with the solution. Kentucky's moving forward with the solution. And maybe there'll be others that do or do not use Medicaid expansion. But until we do get that figured out, until we get the health of our population up, it's absolutely a barrier to the recruiting industry to growing our own here as well. And so again, that's something that I think we need to figure out. So with that, I think I'll stop there with those comments. Again, thank you for having me here today. I look forward to your questions.
Any questions?
Yeah, could you speak to the, I guess, the hybridized program, like in what they're considering in Arkansas, where, they take the stipend that would be allocated for per member fee, and they use it to either buy insurance on the open marketplace or exchanges, or, what's the, we like, I personally like this idea of personal responsibility built in, and people utilize more appropriately, and when they do utilize, they really value what they get. So what's going on in those arenas? What's happening there?
Yeah, I mean, so you see, let me make sure I understand the question.
Yeah, and
right?
the cost.
Well,
And the cost.
And the cost of
us as the taxpayer. I know part of that they're supposed to share, part of that we have to share.
That's right. And I don't have numbers in front of me, but I do know, and I may ask Theresa to help out a little bit with this, and you may know too. But as I understand it, there are some co-pay costs that are shared. I don't think there's a premium, monthly premium in the Arkansas plan, as I understand it. Are there ways to do that? There are probably some different models out there to look at. They've got pros and cons. But I think, could you develop a model where you had some level of cost sharing in there? Yes, I mean, there's models out there to do that. And your question, is that what you were looking for? I didn't get too deep.
I was just wondering where Arkansas was in the process. Are they found something that seems to work, or?
I think it's too early to tell. I mean, we're way early. I mean, it took them a while. It took HHS a while to even approve their waiver to do that. And so obviously enrollment is just starting over there. We need to wait and see what's happened with the cost. I mean, the big question with Arkansas is if you're going to use that hybrid model, you've got to demonstrate that it's going to cost less than what it would under Medicaid. That's really hard to do. And I think it remains to be seen if they'll be able to pull that off. But if they do pull it off, I think it's something we should look at over here.
Well, it looks to me like the third program is where anybody can come in and sign up for a hybridized Medicaid. And then you don't know what the total cost is. And I'm just talking what I looked at it in general. So it's a Pandora's box. We don't know in a balanced budget state what that system would actually cost us. It could just break us literally in 6 months. If you could just sign up for Medicaid. I call it Wallcaid because it's on the Walmart. Our Walmart employees, none of them have insurance.
Sure. So, and I mean, I think we need to wait and see how it shakes out, because there's a lot of, when you start talking about costs blowing up, there's a lot of factors involved with that as well in terms of utilization, who is signing up, how sick are they, all of those, is there adverse selection, all of those things are going to factor into it. And so it does, it's like all of this stuff, right? The more time that passes, the more data we'll have to inform these decisions.
Have they in Arkansas set a definitive package of services, the benefits, or is it just wide open? I mean, you can cap your costs, but we'll pay for food distraction, but not for amputations. I mean, the package that they put together.
I don't know the specifics of it that well to stand up here and speak authoritatively on it.
There's another question over there.
I tried to read the article on the loss of vision, but I couldn't get to it. I wonder if you explain a little bit better. In particular, there will be some loss of vision, but how will there be any difference with the hospital? Can you elaborate on that?
Yeah, sure. Well, so again, originally, so we knew that there was going to be some reduction in disproportionate share hospital payments. We knew that was going to happen. And early on, there was a lot of emphasis focused on that. So we looked at how much dish money was in the state. It was roughly about $200 million a year. And nightmare scenarios were, that's going to all go away. Well, that's not happening. But it is going to be reduced. There's going to be less on the Medicaid side. There's going to be less money going to the hospitals. Now, HHS had to set rules to determine the schedule at which that pot would shrink, basically. And when they did that, they really only did it 2 years out. They said, well, these are going to be the rules for the next 2 years, and then we'll issue another rule after that. Because the dish cuts are backloaded. I mean, they get those dish cuts, the Medicaid ones, get much bigger in the out years of this. But in the next 2 years, they're relatively small. And in states with, high levels of uninsured, they're even smaller. States with high levels of poverty, they're smaller. But the point I made earlier was that I don't want us to just get hung up on the Medicaid dish situation when you look at how hospitals are financed. Because the reality is a number of different federal acts that have been passed over the last few years have had reductions on the Medicare side, which has translated into reductions in revenue for hospitals across the state at much, much higher levels than the Medicaid dish cuts that I just described. And so, I think what my point is that so Medicaid dish cuts are small this year and next year, and they may even be made up. I mean, the governor put out a proposal to fill that gap, basically. And so, but that's not the whole picture. That's my point. If you look at the whole picture, there's another 145 million in cuts that hospitals have to manage. And I guess the other point is if those cuts are truly backloaded, is the strategy of filling in the gap on Medicaid this year by year, is that a sustainable strategy using state general funds as well? I don't think that it is.
The big problem is not looking like March, thinking more on that side of the
As I understand. So as I say, I think forced general would certainly be affected given the population that it serves and the volume it serves. Obviously, at UMC is another one that's going to be affected. And then the other group I put in there is your small rural hospitals that in margins where there are lots of people who are uninsured that live in rural areas. Those are the ones that I think about in terms of that need to be included in the discussion as a bigger discussion of covering lives, financing a way for people to pay for their health care. Yes, Steve.
Go ahead. Some of it.
You mentioned the critical access hospitals and margins. I think there are around 35 critical access hospitals in the state. Now, there's 6 because our hospital just went critical access on December 1st. And for the first time, our hospital administrator is having to talk to the supervisor to get some help. Because it is cost plus 1, cost management plus 1%, but it still is very difficult to manage the budget, and there has been real loss in revenue just across the board because of the decline in the economy. So to your point, the shifting of the tax burden to the local level is a real thing that we're experiencing in California.
That's an answer.
Yeah, just a couple of points. There are 2 ways we look at healthcare depending on perspective. As a physician, we look at it taking care of people. We also look at it as an economic engine for the state. So when we look at economic development in the state, we have healthcare in every county, and perhaps some of the money that is used to attract industry or promote industry in the state can be used to promote healthcare in the state. And that's important for several reasons, not only for access, but it's also for long-term planning for prevention. You're not going to ever get a handle on the cost of healthcare by treating people, because there's not enough money to treat people that have chronic diseases. You have to look at prevention. And prevention has to start at a young age. It has to start in schools.
We had the Healthy Schools Act. It was not funded by the legislature, it was funded through a private foundation. I think made a significant impact on children. All the children don't eat in the schools. We send them because of the food I don't think is healthy. We send them to school. So you have to start by educating people at a young age on prevention. You can't just wait until they have a chronic illness and then think you're going to treat them to health. You're not. You're going to stem the tide. But this is a global problem. We have diabetes and obesity and things that we have to address because we have a higher percentage of it in our state than most places, and are less able to deal with it because of our number of physicians and underserved areas. But when you look at hospitals such as ours in Mississippi Delta, they cut their FTEs about 23% of the past year. That's a tremendous impact on the economy. So if you're trying to improve the economy of the state, you want to stem that tide because these are well-paying jobs. Now, my own practice, I have about 20% of unfunded care. These are people that are basically working for, they don't have Medicaid. And also, and physicians all over the state do that, and hospitals all over the state do that. So those people, they have access to care. It's just that the physicians and the hospitals are subsidizing all the industries that don't provide health insurance for their population. So it's a difficult problem, but there are issues of just, to depoliticize it. You've got that 18% of people who are not covered, and you've already got the Medicaid, Medicare, children are covered, and so that 18%, hopefully, maybe a program through vouchers where they pay some, and they have a voucher, and if you had interstate competition for insurance, which is a federal issue, we can't solve all these problems, but they could have an affordable policy. Young people could have catastrophic loss, young men, below the age of 30, the chance of them accessing health care is pretty low, except for trauma. And so all of these people would have access, whether they choose to avail themselves of it or not, is a different question. They're free to do it or not do it. But, for everyone to sit down and look at health care from a lot of different perspectives, not only from providing health, but economic growth and making the state a more productive workforce and healthier population. Sort of takes a little bit from all different perspectives.
Yeah, I would agree with you. That was one of my goals, was to broaden the discussion to include some of the economic information, because I think it's exactly right. It's one of the largest sectors of employment in the state. For people who live in rural communities and work there, you know how critically important either healthcare practices, hospitals, even if they're small, how important they are to that economy. A couple of things that you said brought a couple of points to mind. One was, I think there's a corollary. So we're part of a community development finance institution and credit union, and one of the things that we see is that kids pick up their financial habits that they exhibit in adults from watching their kids. I think that the same is probably true for how you access your health services as well, what you're exposed to. So I think having parents who are covered is good. And it's not, there's some literature that even says this: if parents are covered and they're accessing services, their kids are going to be more likely. That's even if kids are uninsured. And then the other point is just, to your point, if a hospital in a rural community has to reduce services or even worse, close down, the likelihood that you're going to be able to compete to recruit industry is shot. It's just, when you look at the bundle of services that is marketed to these different groups, having that healthcare provider is critical. So I agree with those points.
We're going to hold the questions for the question and answer period and move on to our next speaker. Thank you, Ed. Next, we have implications of Medicaid expansion and other solutions for healthcare coverage. And our third speaker is Ed Haislmaier. It doesn't look that way, but that's what it is. Am I getting close? Haislmaier. Anyway,
You know where the secret.
you need somebody that doesn't speak English to try to introduce folks. Ed is a senior research fellow in health policy studies with the Heritage Foundation. He's an expert in healthcare policy and markets at the Heritage Foundation. And is frequently asked to help lawmakers design and draft specific reforms for the health system. His expertise includes healthcare tax policy, Medicare, Medicaid, foreign health systems, pharmaceuticals, and healthcare price controls. Mr. Haislmaier, you want me to stop there?
Yeah, I need the point.
I'm already taken up with the first paragraph. Please welcome Ed.
Thank you very much. You missed the most important part. My role is skunk at garden parties. That's what I do a lot of. That's really about you now. Okay, yeah. I'm not going to inflict PowerPoints on you. Sorry. Actually, I'm very pleased that my colleagues or previous panelists did, because it allows me to not have to explain the same data, but simply reference it. I'm going to bring this up, so I just get my numbers right in a couple of places. Anyhow, let me actually follow up on where Ed left off on that on a couple of points, because with respect to, let's talk about that hospital financing issue, because he brought something up, but I want to draw that out a little more. What he brought up is the fact that the biggest cuts that the hospitals are facing are not in Medicaid, they're in Medicare. Now, what that means is, to the extent that the hospitals are going to Jackson or Baton Rouge or Little Rock or Columbus or these other state capitals, and I've been to a number of them, including some of the aforementioned, lobbying for a Medicaid expansion to fix the hole in their budget, they're basically asking you to fix a problem that they have in Washington. It's kind of like you as the physician saying, well, we have a problem with the Medicare SGR, and we want the state government to put more people in Medicaid to fix our problem with SGR. So one of my messages that I've told state lawmakers is tell the hospitals that if they have a problem with the Medicare cuts, go see Congress. Now, if you look at it from the perspective of the actuary at CMS, the actuary at CMS does not believe those cuts will happen because they are so draconian. They were part of the smoke and mirrors used to finance this bill. And so what we are actually looking at in reality is everything that you have seen with the SGR in physician payment in Medicare is now about to happen in Washington over hospital payment. And so that's the perspective you need to have. But Ed's absolutely right. That's where the real money that they're worried about is. And also the other point that I would make, again, I don't mind offending people, never, ever, ever take a hospital's word for anything on anything financial. Never trust anything that they say about their finances, largely because most of them have no idea, even on their own finances. We had a very interesting situation. By the way, all the things you're hearing here in Jackson, I went out, we've had the same fight going on in all these states. But it's politics is very simple. It's hospitals want the money. It doesn't much matter whether the state is, lawmakers, Republicans or Democrats. Some of them might, some governors are going for it because they think it might dress up their budget nicely in the first year or two. Everywhere we look, except for 4 or 5 states that come out as real winners, New York being the biggest because they've already made a complete, do you realize that New York is the other state besides Mississippi with 25% of its population on Medicaid? Did you know that? Because they just generously give it to everybody. But of course they don't pay any doctors, so good luck finding them. But with the exception of New York and a few other states, virtually any way you cut those savings versus cost to the state line on the expansion, the savings are in the first few years and the lines cross and their costs going up after, anywhere between the 3rd and 8th year of the expansion. And you can, my colleague, I have one paper on that. We have other papers, you can slice it a number of different ways. So interestingly enough though, in Ohio, one of the things that they did, this is really sneaky that they actually checked, was somebody went and they looked on GuideStar, which you can look up the 990s, the tax returns of nonprofits, including hospitals. And they looked at the tax returns of the 88 hospitals and hospital systems in the state of Ohio, and they looked at their income and their outgoing, their revenue and expenses, and they took out of the revenue equation the subline of offsets for uncompensated care. They just zeroed it out as if they had never received any offsets for uncompensated care, and then recalculated and found out that only 16, if you had zeroed out all uncompensated care offsets in Ohio, only 16 of the 88 hospitals would have then dipped into the red. The rest are still in the black on their tax returns. So that's another thing, check their figures. That would be the other point that I would make on this. Another point that I'd like to get out of the way, you were talking about Arkansas, and I spent a lot of time in Little Rock working on that. There's no magic in Arkansas in what they're doing. It's a Medicaid expansion. What they're proposing to do is expand Medicaid, but then they would essentially use premium support to buy them into the exchange. And the reason that works is because the exchange subsidies create a set of plans anyway for people between 100 and 200% of poverty that look very much like Medicaid. In a paper I just did on insurer participation in the exchange, and I'm about to testify next week in Congress on this, so I'm going to highlight it on this whole issue of narrow networks. If you look at, people have all looked at the cost share, at the premium subsidies for people in the exchange, but they haven't looked at is the cost sharing subsidies. And if you look at the cost sharing subsidies, it takes that silver plan, because you'd only get it from a silver plan. For somebody at 300-400% of poverty, and I use Covered California, but you get similar designs, because Covered California publishes. I've seen similar designs in other states, because there's only so many ways you can do this as an actuary. But that silver plan is going to have kind of things like a $2,000 deductible, $45 primary care visit copay, $65 specialist copay, $250 for ER, waived if you're admitted, $250 for an ambulance, etc. That's what somebody at 300 to 400% would pay. The cost sharing subsidies pay the insurer to take that very same plan, and for somebody between 100 and 150, the copays, well, the deductible goes from $2,000 to $0. The copays go from $45 and $65 to $3 and $5. And the ER and the ambulance goes from $250 to $25, which is cheaper than a cab in some parts of LA and other places, okay? Now, an insurer is being paid to do that, but they are going to look at it and they are going to know that there is no earthly way that they control anybody's utilization with those kind of copays, no matter how poor the recipient is. And so what they're going to do is they're going to have a narrow network. The problem is that if you're at 300 or 400% of poverty, you're getting that same plan with that same narrow network, but you're paying $2,000 and $45, $50 to go to the doctor. You're not going to be a happy camper. And that's what's going to go on in this. So what Arkansas is looking to do is to accept these people into Medicaid and then buy them into the exchange. As I pointed out, there's a lot of problems with that they're going to discover. It really is a Medicaid expansion, and they have to follow Medicaid rules. And I'll get into that in more, but there's no, the people are looking for a magic bullet, believe me. Again, this is nonpartisan, Republicans, Democrats, this doesn't matter what part of the country you're in. They would love a magic bullet that allowed them to take that extra federal money without all the balls and chains that come with it. Sorry, but you don't. It's just the way it is. Now, let me make one other point, a little off topic before I dig into the solutions, but it's an important point to make, and that's the legal thing. If you look at the court case, and you look at what it did not change the statute. When you go into the Medicaid statute, there's a part where it's mandatory, and there's a part where it's state option. Okay, this is still in the mandatory stuff. So if a state adopts the expansion, they are signing up to say, yes, we agree to make covering this population mandatory for us. Meaning that if they tried to get out down the road, contrary to what HHS has said, the federal government could say, no, this is part of your mandatory, it's all or nothing, the whole program or not. And the lawyers say, if you then tried and went to the Supreme Court would point back to their ruling in Florida v. Sivak and said, that's why we gave you a chance to say no. We said that in our ruling. because the court in its ruling cited the fact that Congress could down the road change the reimbursement rates. They could say we got a federal budget crisis. You know, why are we paying, by the way, in New York? I mean, under this design, you're going to pay, let's take a state like New York or Illinois or California, where there are 50-50 match rate state. You will be paying for this population, the feds will be paying at least 90 cents on the dollar. For the disabled, the poor kids, the pregnant women, the old folks, they're paying 50 cents on the dollar. For a young, healthy adult population, they're going to pay 90 cents on the dollar. How right do you think that target is, particularly if it's blue states have expanded for the next time the Republicans take control of the Senate? And I can write the amendment. It's very simple. We're going to move that Medicaid expansion from the mandatory to the optional side of Medicaid, and we're going to do it at standard match rates. You want to do it in New York and California? They'll be my guest. You put up 50 cents on every dollar, that's fine. Where does that leave you if you do that? Okay? So those are some of the things you have to think about. Now, let's talk really, though, about the population that we're talking about here. Okay? And as my colleagues have done very helpfully, this is 100% adults. I mean, who's not on Medicaid below 138% of poverty? You all know. Kids are on there, the pregnant women, the disabled, the elderly, half the parents or a significant number of the parents, even in a state like this. In some states, like in Ohio, you know, the FPL, they go up to 90, Wisconsin, 100% of poverty for parents, so they're on there. So Mississippi's slightly on the lower range on some of these figures, percentage-wise, but it's not just significantly different from most other states otherwise. So what do we have? We have a situation at 138% of poverty. You have a population, and then you have a population between 0 and 100. Now, what's the delta? The delta is about 50,000 people in this state, meaning that about 20%, in other words, if you go from 0 to 138% of poverty, a certain number of people, I think it's about 231,000, there are various estimates, but we all use the same census data and come to roughly the same. If you say, well, we're not going to expand, well, that means that that group that's between 100 and 138, they're going to get coverage on the exchanges, but assuming that's still around, and that battle's going to continue for years. So about 20% of the problem simply goes away. Now, it's a little higher in most states, about 25%. But even in a state like Alabama or Mississippi or New Mexico, about 20% of the problem goes away. The other are below 100% of poverty. Now, let's zero in on that population because so far the state has not expanded Medicaid. These are the people who will not be eligible to get subsidies on the exchange. Of that population, 86%, well, they're all adults, as we said, 86%, even in this state, have no dependent children. They are adults, able-bodied, no dependent children. I think it's at least 80. Let me see. Let me just double check on that. I might be confusing my number. Let me see here. Did I get that right? No, 80%. I'm sorry, 80%. Yeah, 20% are parents. 80% have, yeah, that's right. It's the difference between 78 and 80. Okay, 80% have no dependent children. 56% are between the ages of 19 and 34. 56%. So we are talking about disproportionately young people, which is not surprising. They're low income. Now, here's the other key reference point for you. If an individual, this is just an individual, household of one, an individual works a full-time minimum wage job, and economists define that as 2,000 hours a week, which you do the math, it's 40 hours, 2,000 hours a year, 40 hours a week times 50 weeks, 2 weeks off. Okay, so that's an economist standard definition of full-time, full year, 2,000 hours. If you multiply that out by the federal minimum wage of $7.25, you're at 130% of the poverty level. So what this means is if you expand to 138% of poverty, somebody can have a full-time minimum wage job at a Home Depot or Walmart, et cetera, and be on Medicaid. In fact, you're going to have a lot of those home health aides and the nursing aides in the nursing homes on Medicaid, treating patients who are on Medicaid. That's point one. So you are going to capture a lot of low wage. And here's the kicker though. What happens, because this is the flip side, this is where I play with stuff. This is the flip side of when we save employers' fines, and I heard this in Michigan and Ohio. I said, wait a minute, how does that work? What that means is, okay, we expand Medicaid, like Governor Kasich wants to do in Ohio. I'll pick on Ohio since I'm not there right now. And what will happen? Well, the Home Depot and the Walmart, they'll all get on Medicaid at full-time minimum wage jobs. And then guess what happens? Walmart and Home Depot don't have to provide them insurance, and they don't have to pay a fine. But you know what? If they have too many hours, or they get a raise, not only do they lose Medicaid, but their employer gets fined for them getting off of a public assistance program. Now, I'm hard-pressed to think of a more backwards welfare policy than that. We don't, it's bad enough what we do with the programs we have where you have incentives for people to stay on them, not earn extra hours, to not cross that line and lose a benefit. Not saying things going to pay up. But nowhere in TANF or any of these other things do we actually penalize the employer for giving you more employment. Nowhere do we actually do that. So from an economic development point, I think it's a really bad idea because you're essentially keeping these people, particularly younger ones, in a situation. It's not good for the economic growth of the state. Now the reverse of that is, if you look at this population that's below 100% poverty and doesn't have it, the question is, well, wait a minute. They're predominantly young. We just saw the data on the uninsured. I can quibble with some of those things, but I won't because they're generally in the right ballpark. They're going to be a bit healthier than the rest. If they do have a condition, it really hasn't gotten serious yet. It's a good time to get it, etc. So we've got this kind of population. So it's not a health issue. Why are you have an income? Here's the question. Why does this person have an income that is less than the income of a full-time minimum wage job? What's going on here? They're not even working a full-time minimum wage job. Well, maybe a job that's sub-minimum wage, like waitressing or something. But here's some of the other possible explanations. One, they're not working because they're in school. Okay, fine. So when in Connecticut they expanded Medicaid, and the first guy that managed to make his way through the thicket of the website and got enrolled was a 30-year-old white middle-class law student who already had insurance but went on to shop to see if he could get something better. But of course he has very low income, and the exchange and the website told him, congratulations, you're on Medicaid. So you can enroll all this on your Medicaid program. Because grad students don't have a lot of income. They're in school. All right? Another explanation is that the economy stinks and they don't have a job, and it's hard to find a job. I believe that. I accept that. Okay? But that's not solved by putting them on Medicare. Another explanation is they have low skills, lousy education, poor motivation, any one of those things. Again, these are all problems that need to be tackled, but it's not solved by putting them on Medicaid. What is solved is the desire of the hospital to get more money. And we're also not solving the problem of the appropriate utilization of care either, and that was referenced here, because there's nothing, as previous speaker said, there's nothing about putting these people on Medicaid that is going to mean that they're going to use the system more appropriately. There's nothing about giving them a Medicaid card that means that they won't use the ER as their primary care doctor. Now, what would you do instead? Again, looking at it as a social welfare policy, I would look at this population and say, number one, do not provide them any kind of assistance without attaching a work requirement to it. Now, by work requirement, I mean the following. This is a broad one. This is standard what we recommend on TANF as well. Somebody is either working, actively seeking work, that means a supervised job search out of the place, or preparing for work. And preparing for work could be anything from VOTEC, getting your high school equivalents, getting to all the way up to grad school. I don't care. The point is you got to be doing one or more of those things in a combination. You should be doing them full time. So if you don't have a job, you should be working on getting a job or improving your skills. That should be the standard that we should set. Okay? And we can be very flexible about that, but that should be tied to that. Okay? So anything you give them, you should start with that. More so than any other population. This population has no excuse. especially if you were to factor out the relatively small number that are parents, and simply, because the state at its own option could simply cover parents up to 100% FPL and be done with it. That's only, I think about 30,000 in the state. Okay, then nobody's got an excuse for this, because they're not disabled, they're adults, and they don't even have kids at home that they have to look after. They could be doing this 40 hours a week. Okay, that's point one. Point two is, if you're going to give them something, it should be very heavily focused on primary care, and it should have strong behavioral incentives to steer them in that direction. That means there should be a very substantial copay for misusing the ER, and what you're really focused on giving them is not so much a comprehensive benefit package, but something that frankly is a mini-med plan with front-end access to primary care. There's a reason why employers in the private market and some governments like Cover Tennessee and New Jersey have essentially created mini-med plans. Now, I know people don't like mini-med plans. Oh, it's not real insurance. That's right, it's not real insurance. I agree. But the reality is, if you're trying to have a low-cost solution for people who it is not economical to spend an enormous amount of money on, who are basically pretty healthy, and you're trying to get them on the right path, and you know that they're already going to get, if something does happen, it's going to get paid for. Because if they're uninsured today and they get hit by a car, what's going to happen? They're going to be in the ER, and it's going to get taken care of, and it's going to be covered by the accountants care anyway. So if you're going to start changing it, focus on that would be my recommendation. So those are the two things, the work requirement and focusing on the primary care. Now, when you do that, if you do it in that structure, if the state does it with their own money, which they can do, and that's another question, which is where would the money come from? That's a legitimate question. But if you're doing it your own, you don't have to ask Washington for permission. If the state does it on its own, there are several ways that you could structure that. One way would be a sort of, debit card kind of thing. Any of you all who are primary care providers who want to sign up and be a participating provider for these people, we'll give them a debit card with a certain amount of money, and they could use it to seek services from you. We'll give them the list, etc. It wouldn't work at the ER at the hospital. Okay, that's one way to do it. One of my colleagues has suggested that. Another way to do it is maybe some of you as primary care providers might be willing to sign up on a capitated basis for a retainer to be their medical home, to be their provider for primary care, and we could, have X dollars paid to you per month, of which 90% is coming from the public purse and 10% is coming from the recipient, so they have incentive and are invested in it. The point is, there might be some good reasons to do that, to say we want them to have not just any primary care, we want them to establish a medical home, we want them to have the right habits, somebody to work with them over a long time. I'm open to that suggestion too. I'm just giving you different alternative mechanisms. But the point is, you're getting what they need and you're diverting them out of the ERs and getting them the kind of care that is most appropriate for those people, as we've seen they need. Third option that some states are looking at doing is, one of the things is that limited duration insurance it doesn't count under federal law. It's a separate category. So all these benefit managers, and this is what they should have done in Tennessee. They should have, instead of dumping Cover Tennessee or the New Jersey equivalent, what they should have done is simply converted it to short-term limited duration, because then they would have avoided all the things in the legislation that makes it expensive. And you can continue to offer that benefit, because if it's for 12 months or less and it cannot be renewed at the option of the policyholder, that meets the definition. Now, the beauty of that is that it fits very well with any kind of integration with a program of education, training, workforce, etc. Because you can say, look, you're covered for 6 months, blah, blah, blah. You got to come back in 6 months, okay? And we've got this work requirement. You got to participate in the program, and let's see if you're up and on your feet. If in 6 months you aren't, okay, we can issue a new one. So it does integrate very well. So the point is, there are all different ways to do that. Now we come to the hospitals. The fact of the matter is that if you do any of this sort of stuff, at the margin, you will divert some of these people out of the emergency room, and you will get them into more appropriate primary care. So the complaint that the hospitals have of the burden of uncompensated care will, at the margin, be diminished. Then, and this I realize could be politically dicey, but this is where the real money is in the system, as my colleagues have pointed out. It's not you, it's not the insurers, it's not the drug companies, it's the hospitals. That's where the money is. That's the elephant in the living room. I would recommend that the approach be to say to the hospitals, fine, rather than having some arcane formula for dividing up dish and non-dish supplemental payments based on your interests, what we're going to do is we're going to do it based on reality and patient needs. So here's what we're going to do. We'll put all that money in one pot, and you are going to claim against it. You're going to file claims to the people who show up who are uninsured and get uncompensated care, and will be compensated out of the pot, and the 100 will be, and you can pick your scale. You can pick the Medicare fee schedule, you can pick the Medicaid fee schedule, whatever you want, but that's 100. If the claims are more than the pot, then you get whatever the proportion is, like 90% or 75% of it. But we're going to put it in a pot, and we're going to actually have you show us the claims of these people doing it. There is very, very little, and I have several GAO reports about this, the Government Accountability Office. There is very, very, very little transparency or accountability in these programs in any state. And as I said, in Ohio, they found that these people, would still be in the black in most cases, even if you took all the money away from them. This is a huge amount of money sloshing around with very little transparency or accountability. If we are seriously concerned about making sure that appropriate care is provided to patients, then I would recommend doing that kind of a pool arrangement with the hospital money. Now, we'll see how the hospitals think about that. So those are some of the ideas that you could do. The other thing is, in the existing Medicaid, is to move the system more towards a consumer choice system. I know physicians are reluctant to embrace Medicaid managed care. The reality is, and I know it's a little anomalous in this state, the reality is Medicaid managed care is more about hospital utilization than it is physician utilization if it's done properly. And I think the better approach, both for the patient and the physician, is what a number of states are doing, to do it on a consumer choice model as opposed to a procurement model. The difference is that states have traditionally gone in and procured, I've got this herd of people, who's going to, run the program for me, as opposed to setting up and saying, well, we're going to have these competing Medicaid managed care plans, and the enrollees get to pick, and the providers get to negotiate with the plans to decide who they're in. They've had a lot of success with the latter in Florida. A number of other states are adopting it. Interestingly enough, in Kansas, Governor Brownback and Lieutenant Governor Collier have been reorienting that as well, moving away from the procurement model to the choice model. And in Kansas, they actually have more choice in Medicaid. They have 3 plans statewide that Medicaid wants to choose from, more choice than the federal exchange, where they really only have 2 plans, because while they have 3, 2 of them are Blue Cross that are that are not overlapping. So in any county of Kansas, don't feel so bad in Mississippi. In any county of Kansas, you only have a choice of a Blue Cross plan and or Aetna in the exchange. But if you're on Medicaid, you have a choice of 3. So even in a state, and I think they have about 4 million, you've got about 3 million. So even the smaller state, because the problem with Medicaid managed care in a smaller state is you're kind of captive, to get them in there, you have to offer them everything, but then the state, the whole ball of wax, but then what if the state isn't happy with what they do? Well, then how do we replace them? Whereas if you have a more competitive system, you don't have that issue. So those are a number of things that you can do. The problem with going the Arkansas way is you're not going to be able to make the meaningful changes that you need to do to address what I'm talking about. You will not be able to put a work requirement on this. You will not be able to have a meaningful differential with respect to this, to a disincentive to overutilize the ER, et cetera. There's a whole bunch of stuff that Medicaid simply won't allow you to do. And as tempting as the money may be, you're just going to have to, accept that you're not going to be able to do those things. So I think we've got plenty of time for questions.
Yeah,
I'm happy to stop. I didn't intend to go long here.
Oh,
I
no.
want to hit the
Plenty of
major
time.
points. And I think, especially for a group like this, it's much more valuable to be interactive with my fellow panelists, I guess, as well. Yes, sir.
All right, so an interesting thing went on with PRM this week. They've shifted the topic of healthcare to minimum wage. So there's cities. public radio.
Oh, right.
We are a liberal
Well, that-
voice out there.
Oh, okay, well, that's White House driven, they want to change the
So,
subject.
exactly, so they're
They
shifting
want to change
the
the subject,
paradigm
yeah.
now to elevate the minimum wage. So if you elevate minimum wage, you've now created an even more impoverished Social Security Medicare group.
Yeah,
And yet their rates, where we've seen with like the Advantage, Medicare, their policy rates keep going up, but their ability to access care is going down. You know, Wall Street Journal this week, where large groups up there in the Northeast now are no longer chosen by the Advantage Medicare to be able to provide the care that they want to do. You know, this whole paradigm now is really shifting into an even more chaos that's not affecting just Medicaid, but now back towards Medicare again.
yeah, and also, and I should mention this, the good news is, because I was on Super Talk before I came here, they, put an interview, and I talked about this, it just happened to come up. But the good news is, I think we're going to see some very positive change. I mean, what you have to look at this, and I look at it, is, for better or for worse, this is an incredibly disruptive, this is a system disruptor. It's really disruptive. It's scrambled everybody's business model and forced them to rethink. What that means to me and to advising lawmakers both at the federal and state level is I see opportunities to do things and change things. And I see, but you have to look and see where the market's going on this stuff and how the market's responding. That's why my analysis that I came out with is, I painstakingly put together an analysis of who are the insurers in and out of the exchange and what are their characteristics. And I'm looking at their dominant business model in the state and comparing them with their peers, and then what were the patterns and what does that tell us? And one of the things that's a pattern in there is that the insurers in Medicaid managed care are moving into the exchanges because it looks like their current market. Anyhow, it's a long paper. But one of the other things which I haven't had a chance to write about, I was talking on the radio about, and I'm going to be working on, is the whole rise of private exchanges, where an employer who's self-insured is not subject to all these benefit requirements in PACA or Obamacare, whatever you want to call it. So they have a lot more flexibility. And now, I mean, for years, I was down here 6 years ago with Commissioner Cheney and Governor Barber promoting the idea of, I mean, I came up with the idea of exchanges, but it was to enable employers to move to defined contribution. So instead of treating their employees like a herd of cattle, the employee got to pick and choose what they wanted. The whole point of doing that was to increase the variety in the competition in healthcare. And what the folks who've done this in the PAC have done is the opposite. They looked at it as a way to reduce diversity, standardize coverage, and fix the and make the individual market look like their version of what it ought to look like. I was looking at a way to make the employer group market look like 1,000 flowers. Okay, and so it's a completely opposite. They're using the same tool. I mean, I'm kind of in the position of the guy who invented the hammer that people went around smashing windows with and say, well, wait a minute, that's not what it was for. Okay, so it's a completely different approach to the tool. What's interesting about this is the reason I was working with states 5, 6 years ago was, and eventually it succeeded in part in Massachusetts and Utah, because I also worked with them, but the reason was because every time I talked to a large corporation, I never got past the HR department, who thought that, well, that's very interesting, but, well, we think we do a better job. I was literally told that by the VP of HR for a major hotel chain in this country, who I said, you got low-wage workers, you've got people come and go, turnover. Yeah, but we provide our people with health care. Frankly, we think we can do better. In other words, I'm better than, at managing the herd of cattle. And they got away with that. Okay? And for years and years and years, all through the 90s, the last 2 decades, I remember this, it was all about these people getting together and saying, how do we become smarter purchasers, better buyers? Okay? Without ever paying attention to the fundamental incentive, which is you only care about one half of the equation, which is cost. They care about both halves, cost and benefit. You got to put it in their hands. Here's what I think has happened. This was so disruptive that it got blown past the HR department and into the executive suite and the boardroom. They were forced to think about things like, well, should we even continue offering coverage to our workers? And I'm talking major corporations. And what happened is they started looking for alternatives, and then the big boys, Powers Perrin, et cetera, came in and offered them. And so now we're seeing this private exchanges, and this is what I'm going to be investigating and writing about, but A.N. Hewitt set it up, Walgreens put 130,000 people in there. Okay? And there include those clerks and cashiers, those low-wage people. Okay, so what you're going to see is a system bifurcating. And when I look at the insurers, I see that because you look and you say, you know, Aetna, Cigna, United. You can look at my paper, I've got everyone listed on there. But they're only in a handful of states. Each one of those, more than half of their national business is employer self-insured for companies like Walgreens. But when you go and look at A.M. Hewitt, Aetna's in there. Okay, they're not in the exchanges, they're only in 14 states. They're in there. And that's where I see some real positive things coming out of this. I see a lot more innovative approaches coming out of that.
What states would be closest to what the Heritage Foundation had a vision for a health exchange?
Utah. They were, unfortunately, they were just getting it off the ground when PACA came along and sort of built it. They're continuing, like New Mexico is, which was sort of doing that, to, they're going to just, for purposes of, call it a shock exchange, but yeah, they're continuing to something important.
Would you say that the state-sponsored exchanges are closer to the Heritage Foundation Vision Exchange than the federal exchange that Mississippi?
Well, no, in terms of, in terms of that state-federal, no. The design is it the individual market or is it the employer group market? The employer group market wants, whether it's Utah or New Mexico shop or a private exchange like A&U. The employer group market, moving employer group to defined contribution, that's our vision. Okay, so they're on that side. The Obamacare or PACA exchanges, whether the federal government runs it like they're doing in Mississippi or the state government runs it like they're doing in Oregon, Idaho, makes no real difference. That's all about standardizing and subsidizing and micromanaging, this coverage. And that's a totally different way of doing it. It really doesn't matter. In fact, it's interesting. It doesn't, I saw no evidence, and I put this in the paper, I saw no evidence that the level of insured competition made any difference. You have states with federal and states with state-run exchanges with more or less insurers. It just really made no difference.
Do you favor any kind of standards for health insurance to be sold in the state?
Sure, yeah,
How would you control that if you're going to let the people select the cheapest? They're going to generally select the cheapest.
well, that's not
And wait, let me finish.
Okay.
What you're going to end up with is a lot of underinsured people. They're going to think they have insurance, but they really don't. They have very little.
Right. Okay. Well, first of all, I don't buy the underinsured argument. That's a subjective judgment.
I've seen it.
Yeah, that's a subjective judgment as to what one thinks somebody else ought to have. But the answer is states have standards. They already have standards. They've
Some
had
standards,
standards.
not much.
No, they have standards. They do. And those are not difficult standards. And there were actually reasonable federal standards in there as well prior to the PACA under HIPAA. And so what I would do is I would allow within those standards variation.
I have one other question. Your point about there's a potential for changing the law dealing with the plans or with the state match. I wasn't sure which you were.
Oh, well, there's a potential for virtually anything in that law to change,
Yes,
but the state match is the point I was making.
Let me point out to you that the match in the existing law was passed in 1965.
Mm-hmm.
I'm not aware of any change that's occurred that's decreased the state match. Is there any?
I don't know, but I
don't think there has.
I do know that the president's budget, and we wrote about this in one of our papers, the president's budget, not this year, last year, it's very interesting, they took it out, proposed a blended match rate, and it scored savings. Now exactly, we have the memos from CMS behind that, but the president's budget is very high level, so it didn't spell it out exactly. But the only way that you wind up having a blended match rate score savings to the federal government is if the states are paying more and the feds are paying less. And my point is simply that with respect to this, given the dynamics of the law, given the unpopularity, given that the Medicaid expansion has been a red state, blue state phenomenon, if you go and if Republicans take over and they were to simply take the match to standard rates.
It has to be passed by Congress.
That's right.
It has to become law.
That's right.
It's a law.
That's absolutely right. But what I'm saying is, it's the question of the have-nots ganging up on the handful of haves. And so what you would be doing is you remember who's getting the money. I mean, everybody talks about how much money you're going to get in Mississippi. Even if you adopted Medicaid expansion in Mississippi, what you would get from the feds is totally dwarfed by what California, Illinois, and New York are getting. I mean, those are the people making out like bandits in this thing. Okay, now I can come up with a scenario in which the U.S. Congress votes to say, you know what, we're not going to be overly generous to California, New York, and Illinois, and we're just going to take the money from them, and I can get 70 votes for that from the other states.
So Mississippi's match wouldn't change.
Sorry? Well, no, what I'm saying is when you look at the distribution of the states that have adopted it, the attractiveness to a budget cutter of bringing that match down is that the savings will come from a handful of very large states. Because remember, in Mississippi, even if you were to adopt it, you're at what, 75, 78% match rate right now? Okay, so if we were to take the match to normal match, you would go from, say, 90% down to 72 or 73%, okay? And you don't have anywhere near as many people. Whereas if you take it down to normal rates, you go from 90 to, or 100 down to 50 in New York, in Illinois, in California.
I just don't agree that it's likely to happen.
Well, I'm just telling you, I mean, if you want, when I look at the federal budget, you know, where do you want to come up with money? And, you know, there's a giant bullseye in my view on that, but that's maybe just a disagreement of how they might play out the federal budget.
What's your impression of this? If you don't have increased money coming into the system, if you have increased regulation causing, increased cost of delivery of care, one thing that some national societies, such as the American College of Cardiology, has proposed is to have evidence-based medicine, so we lower the utilization and try and just have appropriate utilization of high-cost procedures, but lower the overhead of delivering those procedures, and we don't have to jump through a lot of hoops with insurers or whoever to get approval for them. And so to try and have better outcomes and lower costs, how do you see that fitting into the system and being a solution to
Well, that's what you have
being
to
able
do.
to stretch the dollar to do more?
I mean, at the end of the day, that's the reality. I mean, you know, I do this in a more general audience as I talk about this all the time. Look, everybody knows that we spend more per capita percent of GDP on healthcare than anybody else in the world. I mean, you know, and friends on the left are always reminding me of that. And we also are not satisfied with what we're getting, are we? Well, otherwise, we wouldn't be having this meeting. Okay, so here's the problem. It's a problem of value. It's not a problem of money. It's a problem of value. We're either paying too much for what we're getting because we're not happy with what we're getting, or we're not getting enough for what we're spending. Now, the political problem that the administration and the proponents of this law has is they never actually sold the public on why, given that, we now need to take the world's most expensive system and spend trillions of dollars more on it. So the question is, how do you get to value? And I think we can all agree, regardless of politics or party, that we would want a better value system. Ideally, we want a system where we spend less and get better results. More people covered, better outcomes, you know, et cetera. I mean, you know, nobody in this room is going to be against that. I don't care who you are, right? Here's the problem: how do you get there? Okay, because, you know, and I'll take the example. I mean, one of your colleagues here mentioned Cleveland Clinic today before I come up here. Yeah, everybody, left, right, center, they look at Cleveland Clinic, they look at Mayo, they look at Intermountain Health, they look at guys, they say, well, they seem to do a better job at a lower cost, okay? Now, whether they do or not, I'm not going to get into an argument, but that's kind of generally accepted. And so, my point is, okay, fine, but I have a question. Then if that's true, why aren't they eating everybody else's lunch? Because, you know, I got one of these things, it's called a BlackBerry, and they're having a near-death experience because Apple is eating their lunch. And the only reason I have it is my employer gives it to me, kind of like my health insurance, okay? So why isn't that happening in the hospital market? Well, we've got a lot of regulations protecting, a lot of cross-subsidies and payments protecting people. Now, the folks who wrote this legislation don't agree with me. They have a different view. And their view is, you know, we're going to send a team of people in there to study what Cleveland Clinic and Mayo do. And then we're going to go back to Baltimore at CMS, and we're going to write 10,000 pages of regulation to tell your hospital how to do it just like Cleveland Clinic. And that's how we're going to get better value, more, you know, better central planning. I mean, that's the philosophical divide right there. And so when you look at this, I'm all in favor of doing those things, but I'm asking the question, Why isn't the system moving in that direction on its own? What is standing in the way? Because, you know, in every other market, if you build a better phone, you know, if you build a better mousetrap, you start to take market share, and the other guy has to either respond, look at what others have done with the tablet in response to Apple, or they got to say, I'm no longer in that, I'm going to go do something else because I can't compete with Apple, they're too good. And we don't have that right now.
The American cardiologists try to come up with guidelines
Yep.
that have appropriate use of care so that there are some guidelines, I mean, whether people follow them or not.
But see, I would envision a world in which you would have multiple competing private guidelines like that, and you know, if there are good guidelines out there, people are going to advertise it. We follow these protocols. We use these guidelines. Yeah, sure, great.
Are we
Microphone.
are we in the discussion period now?
I think so. I mean, I'm happy
Why don't
to.
we have the other?
Yeah, please do. Yeah, I don't want to be the only one up here.
ACPA question?
And Theresa, would you?
Well,
Should we just tell them there?
I don't know if we can do it or
Otherwise,
not.
it's not. One viewpoint.
We need the mic or just shout. Bring the mic, we'll pass it around. Okay, sure. Sure.
We're way ahead of schedule. He had an hour of time.
When were
to
you
talk.
last at a meeting where we were way ahead of schedule, see?
That's because I'm moderating and not speaking. They know this.
You've done it in spite of me speaking.
See? Two things we agreed on today. My God, it's not ready.
I think these gentlemen have questions.
Yeah, especially in Mississippi, our biggest concern, and really what's got the whole issue of healthcare reform going, certainly in the physician world, is looking at the population of the working poor, and they're the ones who are up against it. And you know, and all the initial initiatives were directed at taking care of that group, the ones that fall between Medicaid and the ability to afford private insurance, and taking care of that. And still, we got feedback on it in place. In Mississippi, I know a lot of us in this room, my main concern is for the working poor in Mississippi to be covered. And to me, one system that has worked is taking care of the children of the working poor, the CHIPS program. They have good access to care, they have good coverage, they get good health care, and we've got 20 years thereabouts of experience with it. Why won't that work to expand it to the working poor? Take that program. Is there no way to get a waiver instead of expanding Medicaid, take those dollars and basically do the same thing that the CHIPS program does to the kids, or the adults that are out there cutting their grass, serving our tables, and doing all the things that working poor Mississippi do? Anybody talk about that?
Well, I'll start off with that, because I was with Department of Finance Administration when CHIP started, and we helped set up the insurance piece of how they were covered. And there was a commission set up that made that decision not to go into Medicaid expansion, which was one of the state's options at the time, but instead to set up a separate private health insurance plan that we'd go out for bid and have that available, because they wanted it to look as much like health insurance plan that the parents had. And because this was a higher income group, they wanted to be able to get the family used to that this is an insurance product. You've got to know who's in your network. You've got to understand there are small copays. Try to help get the population, because it is higher income level in Medicaid, to understand how to use that kind of a product, so as their income rose above that, they would move into employer-based insurance, and they would be used to that kind of a product. And I think it has been successful in the state. It certainly has covered a large number of children, about 68,000 are covered by that, but that's a relatively small number too. In this Medicaid expansion part that we were talking about earlier, the state does have options to set it up different. It does not have to look like Medicaid traditional Medicaid. You can select a benchmark plan like CHIP did, You can have a different delivery system like CHIP did. But also let me remind you that CHIP as it's set up now is more expensive than Medicaid is for children. So it can be more costly as well.
So it's also being folded into Medicaid, basically, right?
Eventually.
Yeah, eventually, CHIP is going away. It's being folded into Medicaid by PACA is what's happening. And the restriction was always for kids. But yeah, I mean, your issue is, you're absolutely right. That's the issue, is tracking that, is to design a solution for that population. But what you mentioned is the families that have kids. And my point is that 80% of these people do not even have kids that we're talking about now in this expansion. So if you're talking about families, the answer is, if the state wanted to do it, would be to simply cover parents up to 100% of FPL. You can do that. And I think it's about 30,000 in the city. No, I'm saying from 42 to whatever it is. Right now, parents are covered up to 40% of 44% of poverty, right? And you could go up to 100% of poverty, and you would add about 30,000 roles. And what that would mean is, under that design, all families with kids would either, if they're below 100%, the parents and kids will all have Medicaid, or if they're above 100, they could be either employer or on the exchange. But this is a different population. This is a population with no kids.
And that also mentioned the similar kind of what Wisconsin's doing.
Well, yeah, but that's exactly what Wisconsin did. Wisconsin was above 100%, and so yeah, they were able to scale back. Yeah, well, that's right. They were, and some of the states, Ohio, we looked at doing some of that as well, because typically a lot of states would go above the minimum. I think Wyoming is the only one that sticks to the minimum for kids. Virtually everyone goes above the minimum for at least kids and pregnant women. So they could now scale back to the minimum, which is the new minimum is 138.
A follow-up to this. Earlier, several years ago, there was a consideration in Mississippi that legislation was introduced to expand CHIP to cover the parents. What was that on? Was that?
What happened, there were states doing that, and this ran into problems at the federal level, because the feds said, wait a minute, that was not what the program was for covering adults.
And eventually they had to take them out.
Yeah, there was a big problem with that in New York and a number of states. States were trying to do it. And the feds basically said, well, that was not what the program was for. The program was for kids. And the other reason that they did that is because the CHIP is not an entitlement, it's an allocated expense. It was only a limited amount of money.
The other issue, and this is deep, have there been any studies of our CHIP population versus our Medicaid population with outcomes? Are children in CHIP doing better? Are they doing better because of the household they're in, or are they doing better because of the insurance?
I only know some studies with CHIP, like for instance, the DFA did a match between the CHIP plan and the health department's immunization records, and determined they had like a 95% immunization rate at 2 years of age. So I mean, that's a really good outcome. It's a good indicator of good care. I'm not aware of the same kind of studies with Medicaid.
The option of CHIP is going to go away because the Affordable Care Act removes CHIP as a freestanding program and integrates it into Medicaid.
Yeah.
Is that what's going to happen?
Yeah, basically that's what happens. I mean, because that population in the PACA either goes into Medicaid or goes into the exchanges. And what they did as part of the PACA is they reauthorized CHIP for like another 4 or 5 years. Yeah, to 2015, so it's got 2 more years to run. Yeah, so at that point, you know, if Congress does not do a further reauthorization, which the law did not envision, then the program would basically sunset. So at that point, because their theory was by that point, everyone who's in the program today will either be on the exchange or employer coverage, or they will be in Medicaid.
The other issue, and then I'll let the other question, is in the CHIP program you mentioned, there's an allocated amount. So for this population, we give you $100,000 and you provide care for them. And this other system is an open box. I mean, jump in and we'll keep pouring money in. I mean, where is there an opportunity to have an allocated amount and then we're going to take care of the population? Something what Oregon did.
you know, we have this money and we have these 500 diagnoses, line up and get the care.
Well, and that's what I was suggesting. If the state doesn't tell, if the state does not expand Medicaid and says, well, okay, 20% of that population is going to go onto the exchange or employers and get coverage anyway. We're not going to look at the others below 100% poverty. We're going to do, and I laid out several options that you could do. Then the state, using its own dollars, could do that. They could design the program however they wanted to do it. They wouldn't have to get any permission. And they could allocate it, they could budget it however they want to, et cetera. So yeah, all of that could be done if the state chooses to do it themselves. That's right. Now, of course, the obvious question is, where's the money come to pay for it? And that's a budget priority question in the state. And I keep pointing back to the fact that you've got hospitals with lots of extra money.
I mean, it sounds like a Medicaid expansion where just the state pays for it all. Is that?
No, because I guess the distinction I make is, first of all, you mentioned it's the working poor. Rule one, let's keep them working and get them working more. Nothing we should do should be counter to them working. And my problem with the Medicaid expansion is there's a lot in it that's counter to those people working. So that's rule number one. Rule number two is this is nowhere near as expansive and comprehensive as Medicaid. And I'm being very upfront about it. I'm saying, there's a reason. I know people don't like mini-med kind of coverage, but that is actually reasonably suitable as an interim measure for these people, And so you're not going to have the full benefit package with the full expense, and you're certainly not going to have all the rules and the reimbursement regulations. You can design it your own way. You can say we're just going to capitate the payments and have primary care homes. You can do anything you want. So you get out a lot of flexibility.
A lot of the arguments have been centered around hospital payment. So I'm a primary care doc in a small rural community just north of here. Every day I look at my 25 to 30 patient roster, and I see 6 or 7 patients that are uninsured. Okay? It's hard for me to look at that nurse aide and think that she can work any harder when she's holding down an extra job. She's using everything she's got to pay rent, gas, to get to the doctor in the first place. I don't know how you can look at that individual and say, you've got to work harder if you're going to get any insurance. I mean, these six or seven people that absolutely cannot afford the insurance.
No.
I don't see how you can look that.
No, I'm not saying that they have to work hard. No, I'm saying if they're working, they would meet the criteria.
Wage argument is coming in now.
Yeah.
That's the new model.
Right, but no. Let me be clear. What you would be doing is you would say, oh, you're working, you're doing the good thing, and you're still below. I mean, if she's working at that level,
Right.
she should be making enough money to be over 100% of poverty. In which case, well, that's a relative. Yeah.
Not according to the health policy institute.
But see,
Yeah, but
these
that's not the problem.
are our $7 minimum wage people. What this argument is that if we raise it to $10.50, then that puts them up to your number.
Yeah, but no, what it does is just means
But it
more of them are
resets the
unemployed.
bar.
It means more of them are unemployed. No.
I think you're for that?
Yeah,
No, tell you what they're doing.
No, what I'm saying is, look, what I'm talking about,
One speaker at a time.
what I'm talking about, the work requirement, is if somebody is working, then they meet the work requirement. So that's not an issue, and you would be providing them assistance. Okay, so if they meet, again, the point is you don't want to go backwards, you want to go forward. If they're working as this person you described, they would meet the requirement, they would get the assistance, etc. Yeah, no, that's absolutely right. The main point is that these people are the exception, not the rule. The rule, the people you're really concerned about are the 80% that are, 19.
Those are the ones I'm talking about.
Yeah, but that do not have families, do not have, and are not working full time. That's what I'm just saying. You want that in there to reward the people who, like the woman you just described, who are doing the right thing, and to assist them. But you also want to do it in a way that you're not encouraging somebody else to slack off, that you're encouraging somebody else to move.
But that's the point that I think we're trying to make, is that these people that we're talking about, the working poor, are working. They're not slackers, right? And I'm missing
No,
something.
you're right. I mean, look, there are a lot of other ways to do this, and we only have this problem because, for example, they designed an incredibly complicated tax
We're
credits
into
for
the
some bizarre reason
discussion
you
period,
don't below
so should I
100% poverty.
raise
Direct
I mean, go
federal
to
tax
4:15
credit
like we
bills
have
have
it
been
there, or
left,
try to
right,
bring
and
it
center
home,
for the
or
last
just see
20
how
years.
the
They never got
dialogue
nothing
continues,
back.
then they wear
You know,
themselves out.
what you do is you start at zero.
I mean, we know, we got,
go
I'm
up,
sorry.
you would have more
We got
generous
more.
tax credits at the bottom
So
and help
we'll
exactly the people.
have
The
at it,
problem is
and
it's a really badly designed law that we're trying to work with. That's not.
Well, our concern as providers
Yeah.
is that this uncompensated care margin that we're talking about, which is getting bigger, is eroding on providers, all providers, ability to stay open.
Well, and we're touching on something else that we haven't, which is the maldistribution in assistance given to providers, where the assistance for DISH and supplemental goes to hospitals, not to folks like you. Now, I'm all in favor of redistributing that pie if you want to. I think certainly that, it would be far better for those people to be seen in a primary care practice like yours, and if that means that we have to take money out of the hospital DISH payments and put it into payments to get those people covered by you, I would go along with that. Whether you can get that through the legislature or something else. But I mean, yes, we've known this for years. This is the problem. What this is showing is all the biases in our system that have built up over 20, 30, 40 years. So we've been reimbursing hospitals, but not physicians.
I mean, I think, okay. Yeah,
I was gonna say, I'm still confused where the money would come from a home loan, state program. You're saying we need to turn down.
Well, I'm saying you're already getting.
Turn down the money from.
Give it to New York.
Well, no, first of all, it doesn't go to somebody else. That's yeah.
You know what you're talking about.
No, it doesn't go to somebody else. It's not a limited pot.
I don't think that all of them is in the hospital. I think the hospital.
I mean, one of the challenges, one of the things that we, the state's been wrestling with over this decision is cost. I mean, the cost is a big. It's one of the reasons. I think. I mean, there's political reasons, but from an economic, if you're looking at a policy proposal, you're going to analyze it several different ways: economic, efficiency, political, administrative feasibility, those types of things. And the economic or cost is a barrier to just going ahead. One, it's not the only, but it's one in terms of just moving forward. The challenge is that I don't know that there is no alternative that doesn't have a cost. Would you concede that? Yes. So there's no policy alternative out there that's going to come up with the solution we're trying to find today that does not have a cost. So the question is, if we're going to put a solution on the table, we have to wrestle with how do we pay for that. Expansion has a lot of federal money tied to it. And it's one reason I think that it should be elevated when it's considered, because of the money that's associated with it. The things that you mentioned may work, we still got to pay for it, and there's no federal source to pay for it. And so, I think that's one of the things that needs to be considered as we make policy proposals, all of them. Even expansion, we need to figure out how we're going to pay for it.
I looked up the GAO reports, and granted, you all may have more recent figures than I do, but the GAO broke this out by states. For DISH and non-DISH payment, federal and state combined, I added up $600 million in this state in 2010. So the question is, where's that $600 million going to? It's going to basically hospitals. What are you getting for the $600 million? This is exactly what drove the reform in Massachusetts. They were dumping $1.3 billion a year in supplemental payments on safety net hospitals. Not all hospitals, just a certain safety net, is really BMC and Cambridge. And when Mitt Romney became governor and the feds said, you've been tweaking the law so much with your upper payment limits and all this other stuff, we're going to disallow some of it. He did the math and he said, holy cow, we could insure everybody who's uninsured in Massachusetts for less money than what we're dumping on the hospitals in uncompensated care payments. Okay? Now, I don't believe that that's true in Mississippi because of the relative difference in poverty and the amount of money. But my point is, before you go looking for new money, if we're spending more money than anybody else in the world, the healthcare system, let's start by saying, what are we spending this stuff on, and really reforming as opposed to simply dumping more fuel on the fire.
I was gonna make one comment on your suggestion about create a pot of money for the hospitals and to file claims for. That's actually what we did before Medicaid expansion. Dr. Cobble, remember the Hospital Care Commission in the state, we had a state pot of money, and it was for uncompensated care, and that's exactly, the hospitals had to file a claim for it.
Did they set their prices though?
This was way back
Yeah,
before.
this is, I mean, yeah, you can't let them say, oh, you can't run it off the hospital charge measure, which is a totally fictitious document. So, you have to have it on some other scale to determine whether the claim is reasonable or appropriate. So you could be a DRG system or something like that. But yeah, I mean, at least it's a fairer system, because a lot of times what happens even within a state is, not all hospitals are treated the same way. This gentleman, I think,
Just one comment, and then I'll have a break. I agree with your primary care. It's very difficult. It's getting more difficult. And after spending a lot of time studying and thinking about this, unfortunately, it's how many 200s and 204s you're going to get rid of. And it's still going to be volume. It's going to get a real key in the near future. I do not believe that fee-for-service is going away in a quick enough time for you to make that difference unless we really enact some other things. Because it is very difficult in our state to take care of the population we have and spend any time with them if you can't. If you don't get enough people to keep the doors open. If Medicaid is expanded, how does the actuarial stuff work? If you can explain it to me, all these people will be covered with Medicaid. When they can't get a provider, the utilization of it will happen in the emergency room. How is that accounted for in these equations?
you mean in terms of the equation of people advocating expansion?
The dollars in the budget for Medicaid.
That's one.
Yeah, well, I mean, you raise a very good question, because the studies that I've seen, and you actually could probably speak more, the two of you, to some of the local state. In some of these studies, there's the assumption that you're actually going to have this reduction in uncompensated care and a reduction in volume. I'm with you on that. I think you're actually going to have an increase. I mean, what we know from the IOM study is that the Medicaid population, again, this is national, so this is going to vary. I mean, it's not going to be as bad here as it is in New York or something. But the Medicaid population, uses the ER at double the rates of the uninsured and 4 times the rates of the privately insured, and double the rates of the elderly. So yeah, there's a lot of reasons to think that exactly that. Now, it might be, I mean, this is all going to be relative. In states like this that reimburse physicians better, I mean, rural states tend to, like Mississippi, even if they're poor ones like Mississippi or New Mexico, tend to reimburse physicians better. They just don't expand coverage to everybody, and that means that you don't have quite that phenomenon. I mean, if you're in New York or New Jersey and you're on Medicaid, I mean, any physician that will see you probably ought to have their license taken away at those rates in those states, and they all go to the ER.
I can tell you for the state employee plan, went back when I did with that, we had the same level of ER use as Medicaid. And I think a lot of it has to do with the lack of primary care and access to.
Bill, to Bill's point, Bill, you practice in a slightly different part of the state than I do, right? Yep. It's more of an urban practice. In my part of the state, I've got, again, 5 or 6 uninsured, no pay. Right down the road from the Heritage Foundation is the Robert Graham Foundation. That's the American Academy of Family Physician think tank. They say the same thing. 5 or 6 unpaid visits nationwide for primary care family physicians. I don't care how much you charge that uninsured, unability patient that cannot pay. I don't care how many 112s or 113s or 114s you charge them, they can't pay the bill. And so what happens is that drives up costs for everybody. That drives them away from my office and into the emergency room. And in a state with the primary care physician shortage as dire as it is in the state of Mississippi, and we're maybe one primary care physician per 2,000, we're up in the Northeast, it's more like 1 to 800. Our situation is exacerbated quickly, and we're sitting here saying no to a large amount of federal money when other states are saying yes to it.
But
It just doesn't make sense.
well, this was the point you made in your slide, is nothing about expanding Medicaid guarantees that changes. And as you just said, it in fact may reinforce that all that new money simply winds up in the hands of the hospitals, and all those people wind up being seen in the hospital anyway. And it doesn't actually change your situation, doesn't change their care. What it does do is it gets the hospital paid. So, I mean, that's this is the problem. And that's what I said. I'm saying, if you're going to do something for this population, if you were to start with a blank sheet, as I did, and say, I want to do something for this population, what do you need? Well, one, you want this work requirement so that anybody who's working is rewarded and anybody who isn't is encouraged to do it. You don't want to reverse on that. And that's a big problem because Medicaid doesn't allow you to impose that. Two, you want to orient the benefit and the payment to the providers. Now, if that means taking the $600 million from the hospital and letting them the $300 million and spending $300 million on giving these people access to you, I'm in favor of doing that, okay? But that's money that's in the system right now. But if you simply throw hundreds of millions of dollars more into the system we've got today, I'm very skeptical that it's going to wind up in your practice. I think a lot of it will wind up in the hospital for a number of the reasons I mentioned.
I mean, but part of it is those, if he's seeing 6 uninsured patients, there's an opportunity there. Now those 6 come through, they've got a payment stream attached to them, they'll come back and do all the things that Theresa talked about in some of the literature, that develop that relationship, catch things earlier, those types of things that lead to better health outcomes.
Maybe, because maybe they're going there because it's close to the hospital or whatever. Yeah, I mean, we don't know about it, but I'm very concerned about it.
I have the same concern about access to primary care, but I'm afraid other people are 2 steps ahead of us in the thought process. Robert Wood Johnson Foundation commissioned the Institute of Medicine to do a study to find that physician extenders deliver equivalent care to physicians. And with the idea, I believe, that they're going to say, well, okay, if primary care physicians can't deliver the care for this amount, then we've got nurse practitioners, whoever can. I think they do a great job. They're extenders of physicians. They're not replacements of physicians. No plausible argument to be made for someone who has, extensive amount of training is going to deliver more care than someone who has limited amount of training, although they have a little. But so the Robert Wood Johnson issues a study at the Institute of Medicine. The Institute of Medicine concludes that physician extenders deliver the same level of care as physicians. You go back and look at the data, where they base that on, they had one study of 100 geriatric inpatients that were randomized between a physician and a nurse practitioner. And they had 3 references. The first was the study reporting a 6-month follow-up. The second was the same study reporting a 2-year follow-up. And the third was referencing those same studies. So it was basically one incidence of geriatric 100 patients, inpatients, and from that they extrapolated that primary care, that physician extenders deliver the same level of physician. It makes no sense, but that's what they base their argument on. You would think the Institute of Medicine, as esteemed as they are, would not do that. But they came up with that conclusion in the submission of Robert Wood Johnson Foundation. So I'm afraid people are 2 steps ahead of us on this thing, and they're not interested in, the necessary quality of care. They're interested in controlling care from a different perspective, and that concern.
Hey, I'm interested in your suggestions about the category we talked about, younger working people. The problem they're going to have, if it's catastrophic, is going to be some type of trauma or perhaps a cancer that's diagnosed. So what's the backstop, or what's the mechanisms for a backstop for those folks so that you know, if they have something over 5,000, you know,
Yeah.
I have a nurseryman that I go see, and his son got bit by a water moccasin, had an inflammation, had like a $70,000 bill. He had a 5,000 policy. He says, look, I got great care, but if I didn't have that policy, it would really set us back. So what are some of the mechanisms to kind of cover those folks?
Well, again, the problem is that this legislation makes it very difficult to do that other than giving them a very expensive plan. That's the problem with the legislation. I mean, look, if I was designing this, or if we get to redesign this thing, you know, yeah, we would totally rework this because they've engineered them into a very expensive plan. So what happens? So I fall back and say, what happens to those people today? Well, what happens to those people today is they wind up in the hospital with uncompensated care. And so I say, well, okay, some of that is still going to wind up in the hospital and be uncompensated care, and that's where you pool the bad debts. But let's get as much of the stuff that doesn't have to be there out of the hospital and into the hand, and let's pay the primary care physician to see them for the other stuff and get them in a regular relationship with a primary care physician to minimize the extent to which they go down to the hospital. I am not making any representation that this is anything close to an ideal solution that I'm talking about. What I'm saying is I'm trying to give you ways to work around this problem that you've got, which you've been given a very expensive, very unworkable thing, designed by people who had a different set of objectives in mind.
So there's no kind of state work.
Well, see the problem. Well, the problem is, yeah, you could do it. I mean, but you would have to go. The state could do it. It would take a while. You would have to go into what are essentially non-qualified insurance products. In other words, they would have to be things that evade the federal mandates that make the whole thing very expensive. So you could do it with some hospital indemnity, but you know, for people like that, it's just, you know, again, for the effort to do that, that's not where I'm trying to deal with. It's like the prayer book. I'm trying to deal with, you know, 80% of the problem. You know, here you get 80% of the problem. The thing is, look, we can deal with a fair amount of this. We're not going to eliminate it, but there's a huge amount of money going to offset the hospitals for uncompensated care. Fine. Can we reduce and can we move more of these people's care into an appropriate setting at an appropriate time, meaning earlier for a lot of this stuff? And that would be in the primary care offices. Can we spend some of that money to do that and marginally reduce it, realizing that if that patient of yours gets hit by a car, they're going to wind up in the hospital. The hospital is not going to be able to collect a dime on them, but they are going to get dish money. But that's what's happening today.
Off the wall question, how long does the system last before the funds go back to your
Are you talking about the overall?
Yes.
Yeah, I get asked that a lot. People think about it, and people talk about death spiral and whatnot. I don't see it imploding here's the thing. I know what the end state looks like. Look, this has introduced a massive disequilibrium into the system, and the system is going to reach its new natural equilibrium. The new natural equilibrium is that in spite of the premium subsidies being from 100 to 400% of poverty, the reality is, I believe, we will see within a year or so, I would be surprised if we didn't, that the exchange composition will consist of people principally between 100 and 200% of poverty, principally on the older end of the scale. What it's going to attract is people who were forced to take early retirement because of bad economic circumstances. That's what it's going to attract, and I see a lot of that. They will have very generously subsidized coverage. It will, very low. I mean, when you look at the subsidy scale, the copays, as I mentioned, are very low. The premiums are what they have to pay are very low. They will also have very limited access. It will be provided principally by Medicaid managed care type plans with limited physician and narrow networks of physicians and hospitals. That's kind of the end state. The question in my mind is how soon do we get there? If you were to enroll in the next 6 months a lot of young, healthy people, the process of devolving towards that end state could be drawn out for a number of years. If you fail to enroll offsetting good risks, then we could reach that end state in 12, 24 months. It basically, the end state, the equilibrium state, is a giant sort of high-risk pool Medicaid kind of extender to 100 200% of poverty. That's what the end stage. Everybody else with money gets out of the system. And as I said, because of the narrow networks, even if you're at 300 or 400% of poverty, you're not getting enough subsidy to be worth putting up with a narrow network. So you go look elsewhere. And if you can't get it on the exchange, you get it outside. It's going to take a while for that to kick in. I think it's very interesting. None of the insurers, for example, who specialize in providing individual market coverage, and they're relatively small insurers. There are a couple national ones, but they're relatively small because most individual coverage is provided by local blues. None of them are in any of the exchanges in any of the states. Okay? So the insurers, and this is the paper I just did, the insurers in the exchanges are three groups, and Mississippi is an exception. The Blue Cross plans, 62 Blue Cross plans, all but 3. Mississippi's one of them. Wellmark, which is South Dakota and Iowa, are the other 2. And they, interestingly enough, are running ads poking fun at the exchange, saying, good thing that you don't have to go there to buy insurance. You can come to us, which is look for that coming here and elsewhere as well. But the Blues are in there. They're the dominant carriers. They're going to dominate this market. That's one. The other group that's in there by a 2-to-1 are carriers whose principal business is employer group coverage. They're looking at their market eroding as employers drop. They're going to have to go in to catch them. That's why Kaiser, which is in 8 states, every state that Kaiser does business in, they're in the exchange. Because 75% of their business is employer group, and if that erodes, they're toast. They're trapped. It's the local regional HMOs like that that are going to really be squeezed. It's not that they want to be in, they feel they have to be in. The large insurers, as I mentioned, Aetna, Cigna, United, who deal with large employers mainly, their business, over half their business is ASO for self-insured plans. They're testing the waters. If it gets better, they'll come in a few more states. If it doesn't, they'll be gone next year. Okay. And the last group that leaves is Medicaid managed care, Centene and Molina. I mean, Molina is in every state where it does business except Louisiana, where it doesn't have an at-risk contract. Centene is in 14, it has Medicaid managed care plans in 14 states. It's in 7 of those states, but those 7 represent 70% of their Medicaid managed care business. I quoted the CEO of Molina was quoted in the Miami newspaper saying, Medicaid is individual market coverage subsidized by the government for poor people. The exchange looked very similar, that's why we're in.
When the whole Affordable Care Act business, has come up through the years, my concern has been the fact that it's going to be paid for by taxpayer money. It comes from us. So now that it's happened, this is just being very selfish, but why do I want my tax money to go to California and New York? Why don't I take advantage of having it come into my state?
It's
Especially since ours is such a small percentage.
It's tempting, it's not. Only part of that's tax money, part of it's Chinese money that they lend us. And part of it is those mythical cuts that are going to occur on those hospitals. That's how they're paying for it too. Remember all those hospital cuts that we're talking about in Medicare, that's how they're paying for it as well. So, if you're drawing down on that money, you're just making the need for those hospital cuts greater. So, it's a mix of things.
Under the ideal plan that they had for the system, how much of it was coming from this pool business of getting the people who don't use much service to buy, like young people, and how much of it was coming from the direct taxes that are labeled in the law?
Yeah, it's a good question. I'm trying to think. I haven't seen that teased out.
I haven't seen it.
No, I haven't seen it teased out. It is a good question because this is why I sort of scratch my head about some of it because, on the one hand, you say, oh, these people are going to come in and they're not going to use the services and they're going to pay the premiums. But then I said, wait a minute, these young people are all low income and you're heavily subsidizing the premiums, they're not paying the premium. So, how do you figure that, you see what I'm saying? So, yeah, I'm puzzled by that as well. I think, basically the overall financing of the bill is pretty straightforward. About roughly half of it is a Medicaid expansion, roughly half of it is these exchange subsidies, and roughly half of the pay for is new taxes, and roughly half of the pay for is cuts to the hospital, to Medicare reimbursement, particularly for hospitals. And plus or minus the margin, that's roughly built in its basic structure. But yeah, see, that's why I don't put a lot of, as I said, I think the degree to which younger, healthier people buy into the exchange, all that does is it varies the time that it takes to reach the end point. If more come in, it might take a little longer. If they don't stay out, it might, default quicker.